Hi, everybody. Beautiful day. Welcome. I'm Barbara Rothschild. I'm one of the core faculty members in the Master of Bioethics program here at Columbia University. Before we get started with today's program, I wanted to let you know you can check out our website online for some future programs, including a CLE on most end-of-life forms, and also a 51st at this point anniversary of the removal of homosexuality from the DSM. We'll have a panel discussion thinking back on the history and then its implications for ethics today, which would be great. Let me see. Oh, and then we have recordings of previous just recently. We have Dr. Bob Klitzman, our director, interviewing Dr. Anthony Fauci, which is fantastic. So I also recommend that, also on the website. Welcome to Ethics for Lunch. When I was in medical school, I loved to hear an ethics case while I ate free lunch. So this is like the best thing ever. And now you can see where I got. So it had implications for my future. Today, we are so fortunate to have leading us through a very difficult case, Dr. Lydia Dugdale. Lydia is the Dorothy L. and Daniel H. Silberberg Professor of Medicine at Columbia University Medical Center and the Director of the Center for Clinical Medical Ethics. And I might add, they also have some pretty fantastic events, so check out their website. She serves as the co-director of clinical ethics at New York Presbyterian Hospital here at Columbia University Medical Center. She is a practicing internist. She came to Columbia in 2019 from Yale University, where she previously served as associate director of the program for biomedical ethics. Her scholarship focuses on end-of-life issues, the role of aesthetics in teaching ethics, moral injury, and the doctor-patient relationship. And I know she has a fantastic book that I often recommend to my students, The Lost Art of Dying, a popular press book on the preparation for death. She attended medical school at the University of Chicago, completed residency at Yale, and holds a MAR in ethics from Yale. We are particularly fortunate to have Dr. Dugdale take us through this case today, as she is a deep and empathic thinker around end-of-life and quality of death issues. The word physician comes from Greek and Latin, physica, meaning nature, and the Old French physic, meaning cure or remedy. This case challenges both of those origins by the introduction of life-saving technology and the notion of performing an act upon request that has a very high chance of resulting in death rather than life. And of course, it challenges our ideas around body integrity and our rights to our own destiny. All in all, a very complicated case. And again, it is our good fortune to have Dr. Dugdale help us gain the skills and knowledge to think about it.
Thank you, Barbara. Thank you all for being here. And for those of you on the Zoom room, I guess there's the camera. It's a delight to be here. Thanks to Dr. Bob Klitzman for the kind invitation, to Dr. Barbara Rothschild for the lovely introduction. And I loved the shout out to the etymology of the word physician. And thanks to the team for hosting today. So I guess I should start, well, I have no disclosures. It would be great if I had some sort of patent to a heart device, but I don't. And I also should just give you a disclaimer, which I didn't make a slide for, but my disclaimer is that I'm not a cardiologist. I have no particular expertise in cardiac implanted devices. I am a primary care doctor and a clinical ethicist. And so I come to this case as in that capacity as a clinical ethicist. And here at Columbia Presbyterian, we've had a number of requests from patients to have their LVAD removed. LVAD, this acronym, as you can see in the title slide, referring to a left ventricular assist device, or for our med students in the room, especially the M1s, this is essentially a pump to the left side of the heart. So when the left side of your heart fails and your heart doesn't pump that well, this will be a device that can be implanted in a sense to pump the blood for you. So let's go on. So chief complaint, I'm presenting this in the format of a typical medical case, which is we give the medical details and then we'll sort of talk through it. At some point in this presentation, I'm going to ask those of you in the physical room to just shout out some brief responses, emphasis on the brief. And what we'll do, because we're not going to pass the mic for that component, I will repeat your brief responses back into the microphone so that those on Zoom can hear. All right, but I'd love to have you be engaged. And the M1s who just heard me lecture a couple of days ago know that I love it when the class gets involved. So hopefully we can have a good conversation together, and then we'll leave some time at the end for questions. Yeah. Great. All right, so here is the case. We have an 80-year-old gentleman, former smoker, history of anxiety, panic, and depression, what one of my friends calls the New York syndrome. History of TIA, what we call a mini stroke, NSTEMI, which is a heart attack, with some resulting heart problems, namely that his heart does not pump well. That's what this EF of 15% means. His heart is only pumping at about 15%. We're happier when that's about 60, 65%. So in 2013, then he gets this LVAD, this left ventricular assist device placed. This is a surgically inserted heart device, some of which is on the outside of the body. And I'm going to show you an image of that just so that we're all up to speed on that. And he is admitted to the hospital for attempting to cut the lines to this device. He was attempting to disconnect the wires that power this device. One other piece of information, and we're not going to dwell long on the medical facts. I know that the medical doctors in the room would love to spend a long time on the medical facts. I'm just giving you what we need to know for the sake of the discussion. But he did come into the emergency room a couple of weeks prior because he was complaining of a lot of abdominal pain. He said he had had about a 30-pound weight loss in a few months, maybe 3 months or so. And he had been admitted for failure to thrive and had had a GI workup at that time. So trying to figure out what the cause of his abdominal pain was. They couldn't find anything acute. They sort of gave him some nutritional supplements, made sure he was completely stable, and sent him to a rehab facility. And it was there in the rehab facility where on several occasions, actually, he tried to disconnect these wires. So going back here, I failed to mention this. He had a replacement or an upgrade a couple of years prior to admission. Okay, so what happened is that the LVAD that he had was an older model. A new model came on the market with significantly fewer risks, and so they upgraded it a couple of years prior. I will note that average life expectancy, median survival, not average, but median survival with this new device is 4 years. So he's already had it a couple of years. Okay, this is what it looks like. It's the HeartMate 3 for those of you who are excited by these things. I'm not promoting it. Here's the anatomical heart in the body. This is the device, and essentially especially for our med students in the room and actually for all the attendings who forgot their anatomy, what this does is it takes the blood from the left ventricle that usually would be pumped through the aorta there, the big blood vessel that sends blood to the whole body. It takes that blood from the left ventricle and it pumps it through this kind of hose-looking thing, and that's inserted into the aorta. So basically, again, because the left side of the heart is failing, the natural pump of the heart is not working. So this machine takes the blood, circumvents the pump that doesn't work, and sends it to the rest of the body. So it's really a brilliant technology. Now, for the M1s who are doing their cardiac anatomy, have you guys done that yet? Yeah, a little bit. Okay, I saw a little bit. Okay, so you might say, well, usually that blood from the left ventricle goes through the aortic valve, right? And so now we are circumventing the aortic valve. What happens to the aortic valve? That's exactly the right question to ask if you're wondering about the heart anatomy. That valve does have changes to it over time and becomes more and more insufficient, we say, over time, the longer this machine is in place. I'll also say parenthetically that on the whole, most people become more and more dependent on these machines the longer they're in place. although from my preparatory read for today's talk, there are some case reports of hearts actually improving such that the devices can be removed. But that is very much the exception. Okay, this is another image. And the reason why I'm showing you this image is because I put this right here, this little, see here, I wanted you to know what is visible and what is not visible. Okay, when you hear that a patient has an LVAD, what do you actually see? Well, you don't see the heart, for one, but neither do you see any of this pump, nor do you see this line here. So it's starting from where I put the red circle. All of this will be external to the body. This is the control pack. These are the two battery packs kind of slung over the shoulders, if you will. You carry those, you have to have those on all the time. This is what is giving fuel to the control, which is allowing the pump. And note, there's two battery packs, right? So if one fails, you're always in good shape. Your heart will keep pumping. So our gentleman, our 80-year-old gentleman with lots of medical problems, he had been trying to disconnect these wires here from the control to the pump. Okay. So just a little bit more past medical history so that you know this is more than just an older gentleman with a history of stroke and bad heart and New York syndrome. This is also a gentleman with kidney disease. He has chronic fatigue from a history of EBV, which is Epstein-Barr virus that causes mono. Okay, so he had mono, and he never really got over the profound fatigue from that. He had DVT, which is a deep vein thrombosis or a deep vein blood clot behind his right knee in 2018. This required him to be on blood thinners, but then he developed problems from the blood thinners, could no longer be on them. That's what the HIT positive refers to. He also fairly recently, the year of presentation, had a GI bleed, and he also wrong date here, sorry. He also had an abdominal hernia that was inoperable. And when he had the abdominal hernia, he was very distraught by the presentation of his body and was very upset that the surgeons could not fix it. So essentially, essentially his abdomen had a malformed appearance, and he did not like the way he presented. Just by way of social history, a little bit about him, married 2 adult children. He has a third daughter who died about a year prior to presentation, a bunch of grandchildren, very close family, very loving. The wife and kids were in frequently to come see him, even though it was a bit of a commute for them. He worked in construction and really no vices to speak of. So, for the non-medical people in the room, we'll just put them together as an elderly gentleman with anxiety and depression, with a very complex medical history, actually, including what we would call life support with this implanted heart device. Recently in the hospital for abdominal pain, discharged to a facility, now brought in from the facility for what we consider to be a suicide attempt. And he is here because he was trying to disconnect his left ventricular assist device. We all on the same page, because this is where I'm going to ask you to just shout out a couple of things, right? Okay. So I want to know what ethical issues this raises for you. Just shout things out. Yeah, please. What happened to patient autonomy? Yeah, well, why are we even having this as an ethics remark? Don't you just like cut the wires and be done with it? Right. What happened to patient autonomy? What else? Yes.
Is there an ethical difference between not wanting the LVAD placed and then versus want to get out once it's already in place? Like, are those morally and ethically different?
Sure. So we might say, is withholding a particular treatment ethically distinct from withdrawing a particular treatment? Great question. What else comes to mind here?
What is before the chat?
Well, anybody on the chat have anything?
What is suicide?
Yeah.
Suicide?
Is this suicide? Excellent, right? You're saying, what about his autonomy? And is this even suicide, or is this the removal of life support? We remove life support all the time, right? I saw another hand. Was there another hand? Okay,
On the chat, someone said, does it matter that he is married and has grandkids? What if he didn't?
terrific. Does it matter that he is socially connected, embedded in a community? And grandkids raises the question also of age. What if he were a 25-year-old man? Would we think about things differently than if he's an 80-year-old man? Terrific. So when I thought about this, I had these questions. Is this even suicide? Is this a request for suicide? As a society, we have taken a stand against suicide. We spend gobs of money to prevent suicide. Is this even suicide? Is that what we're talking about? Or is this just an attempt to remove life support? And is a removal of life-sustaining treatment, that's the LSD, is a removal of life-sustaining treatment the same as assisting suicide? Is deactivating an LVAD the same as removing a mechanical ventilator? Are those ethically analogous? Does his overall health status matter? What if he were an 80-year-old with zero medical problems but a bad heart, playing golf every day, and I don't know, running for president, you might say. Just kidding. Does that matter? Is that he's so sick and that he's been in the hospital and been in the nursing home and the rehab? Does that matter? And then something that I think your question about his autonomy gets to this also is what role does determining capacity play, right? Because to say he has autonomy means we have to determine that he has autonomy. And when patients ask clinicians for something that makes clinicians uncomfortable, the first thing we do is try to figure out if the patient is thinking clearly about their requests. Okay, so when we were preparing for today, we realized that for some of us who've been doing ethics for a long time, there are certain cases that are sort of built into our vernacular that younger generations might not know anything about. And so this is kind of a question for the older folks in the room, but what cases are critical to our parsing through this current case? Cruzan. Okay. And I'm also thinking of Quinlan here too, right? So we're gonna just do a very brief touch on so that we're all up to speed, because these cases, especially for our med students, these cases are critical to know that they happened and how they affected case law. So Karen Ann Quinlan, this is 1975. She's a 21-year-old young woman. She goes to a party. She had been doing some pretty radical dieting to try to fit into an outfit. So she hadn't eaten, we think, for about 2 days. She's at the party. She has a few gin and tonics and takes some Valium and becomes non-responsive. And as it turns out, she codes, she's resuscitated, and she ends up being in a persistent coma. I'll just say that persistent vegetative state, persistent coma, there's a lot of different language that is used. And to me, it seems that there's still not quite consensus, at least people aren't all using the same language. She's not brain dead, so she's alive, and she's not conscious, okay, to the best we can assess. So I'm using persistent coma in this regard. And she requires chronic ventilation. So she's hooked up to a breathing machine, and that is breathing for her because she has such bad brain damage to the brainstem that she would not breathe on her own without this ventilator. Now, I note that her parents are Catholic, and that's important because at this point in history, no one had seen it as permissible at all to withdraw a ventilator. That was considered killing. That was considered not just hastening a death or allowing a natural death, but it was considered overt killing, or what some people will call passive euthanasia. So Why do I mention that her parents are Catholic? Because in the Catholic moral tradition, there's a distinction between extraordinary and ordinary means. And her parents said, look, this mechanical ventilator being hooked up to a machine, we're not advocating for killing her, but this is extraordinary means. This isn't ordinary means. This isn't like nutrition. And so they went to the doctors and they said, can we remove this? And the doctors refused. The doctors refused because there was this had not happened before. At least that was publicly known. Okay. So the parents sued. They're in New Jersey. This goes to the New Jersey Supreme Court. And the Supreme Court ends up, actually, they hired a lawyer who still, to this day, works for the Vatican. So he was a lawyer who knows both the Catholic moral tradition and case law. And they found in favor of the parents that this is, in fact, an extraordinary intervention. They withdrew it. However, Catholic moral tradition also, it can be interpreted that artificial nutrition and hydration is not extraordinary, that's ordinary. There's not total consensus on this, but most people in that tradition would say, yes, continue nutrition. So the parents continue feeds. And it turns out that not on the ventilator. Even though we thought she was ventilator dependent, Karen Ann Quinlan lives another 9 years and ultimately dies of pneumonia. Okay. Next case, yeah, Barbara.
I just, in some ways, it also reflects how new that technology was in the moment, why they didn't realize she was going to speak, to bring on her own afterwards. And so this is also sort of these moments where technology is quite new, and there's a lot of uncertainty as to what its effects will be.
Yes. So Barbara's point is well taken. This is very new technology. I mean, it was really late 50s and 60s when we started experimenting with the mechanical ventilator. And so by the early 70s, this is quite new. It's not in widespread use. So that's a really important point, which is probably why we don't have case law on it, right? Okay. The other case that I want to call to your attention is Nancy Cruzan, which was the first one that you suggested. Now, so we said Karen Ann Quinlan was 1975 when she had her overdose, and now we're 1983, so early 80s. Another young woman, motor vehicle accident, and she ends up in what I'm calling a persistent coma. However, she did not need a ventilator. She just had a feeding tube put in. Ordinary means, right? This is what we know at this point. And after 5 years, her parents requested to have the feeding tube removed. The doctor said, no, you need to get a court order. The parents got a court order. At this point, the state gets involved. And Nancy Cruzan is appointed a state guardian over the objection of her parents, right? So guardianship of her is taken away from the parents, is given to the state guardian. And this is in Missouri. And the state rules against stopping the feeding tube. They said, you may not refuse for another without evidence. Her parents appealed, and this goes to the U.S. Supreme Court. The case in the U.S. Supreme Court, it wasn't until 1990 where that was settled, Cruzan versus the director of the Missouri Department of Health. And it's interesting that this case affirms the lower court decision. Now, if you go back, the lower court said, you may not refuse without evidence, and they're affirming it, but in sort of almost the opposite way. They're saying it is acceptable to require clear and convincing evidence. So it's not, you may not refuse, it's now a positive, get the evidence and we can consider removing life support, which is exactly what her parents did. And she she was working, I think, in a home for folks with disabilities. And so she had conversations about how you would want to live or die, what kind of state would be acceptable. And multiple people had had those conversations with her in this setting. And so the parents came up with this proof, and they were permitted to remove the feeding tube, and she died. This notably led to the creation of advanced directives. So if I just put these two cases together, the Quinlan case and the Cruzan case, this is kind of the impact that they've had on how we think about engaging with removal of life-sustaining treatments. These cases establish that competent patients, which neither of these women was, right, have a constitutional right to refuse medical treatment, including life-sustaining treatment. So any competent adult can refuse any medical treatment they want to. And that in cases where a patient is incompetent, like our two ladies here, a state can require clear and convincing evidence of their wishes before allowing the withdrawal of life support. So here's the question for us. Is there something different about the LVAD? Why are we even discussing this? Isn't this just honoring autonomy and removing life-sustaining treatment? And that's where we're going to pivot to this next part of the conversation. For this conversation, I'm going to work off this paper. All four of these individuals named on this paper are or were cardiologists and ethicists. And so it's fitting that we look to experts in the field, experts in this technology to help us think through the ethics of it. Sarah Hall was a colleague of mine at Yale, and Jim Kirkpatrick was a colleague of mine at University of Chicago. May his memory be for a blessing. Okay, so what they say in their paper, and I'll just note that this paper draws heavily from the work of Daniel Scamesi, who's a physician and a philosopher and an ethicist. So his work is implicit here. And in fact, some of these distinctions that I'll walk you through on this slide, which comes from their paper, is actually directly tied to Dr. Scamesi's work. So thinking about LVADs in particular, first of all, we want to ask the question, when we're talking about withdrawal of life-sustaining treatments, does it matter if the technology is external or internal to the body? And that's this first, the column on the left, right? So external, and so then we're thinking about LVADs in particular. They can be understood as distinct from the body. Certainly they have batteries and controllers that are external to the body. And they require clinician oversight. This isn't like you walking around with a kidney transplant and it's you and your kidney all the time, right? There's definitely external component, but they're also quite internal, right? And that's why I showed you that earlier image. They're intrinsic and they're implanted, they're surgically implanted. And as I mentioned to you earlier, the longer that LVAD is in place, the more changes happen to the aortic valve, which means you become more and more and more dependent on the LVAD, even in the setting of advanced heart failure to begin with. Okay. Then there's this question, Dr. Scamesi and our cardiology ethics colleagues here make this distinction between what they call regulative and constitutive therapies. So regulative is something that, in a sense, regulates a particular function in the body and restores what they're calling homeostatic equilibrium. Okay, what do we mean by that? Well, think about a heart rhythm being abnormal. And you have that ICD in place to keep it going back to normal. It's regulating. It's constantly regulating back to normal, but it's not replacing your heart, right? But then there's constitutive, and then our colleagues here distinguish between constitutive that's a substitute and constitutive that's a replacement. So for example, hemodialysis, I mean, it is so critical to constitute normal kidney function, but it actually, it's not your kidney. Your kidney is still there. Whereas if you actually have a kidney transplant, that's not external, it's not, it's as replaced as you can get. I think, so let me just show you this. This is the way I dumbed it down for myself. If we were to think about how to put the LVAD in context of that chart I just showed you, on the one hand, and this is what Tom, you brought up earlier, there's withholding life-sustaining treatment, which seems sort of the least ethically problematic. As we proceed along here, it becomes more ethically problematic. So if we jumped all the way from withholding a treatment to thinking about explanting a heart that's already in and already been transplanted into a body, we would never do that, right? We would never say, oh, you're 80 years old with a million medical problems and you're ready to die. We'll just cut your heart out, and make you comfortable, right? So we won't do that. So this is the order that in their paper and that chart I just showed you. This is my very dumbed down, simplified version for myself. So then there's withdrawal of either regulative or constitutive treatments, therapies that are external. So we can think about a mechanical ventilator. On the one hand, the mechanical ventilator is regulative because it's helping to keep the carbon dioxide and the oxygens in balance. On the other hand, it's a little bit more like a constitutive substitute because it's actually functioning as your lungs for you, right? So you can see how a vent is kind of a good example of both regulative and constitutive, but it's still external. But when we move to internal, we get a little bit less comfortable taking things out. And you can think of, again, the regulative, restoring that heart rhythm. It's not replacing the heart. It's not even kind of acting like the heart. It's not the heart at all. Are we comfortable removing ICDs? This is something else that clinical ethicists get called about semi-regularly. Can we deactivate an ICD? And then the transplanted organ, probably the most ethically fraught. So how do we characterize removal of the LVAD? I mean, where does LVAD fall in here? It's worth stating at the outset that there's no consensus. So when they have surveyed cardiologists, for example, the majority of cardiologists feel that deactivating an ICD or removing an LVAD is a kind of euthanasia. Whereas 100% of palliative care doctors surveyed see this as a withdrawal of life-sustaining treatment and allowing a natural death. And even among cardiologists, there is there's no consensus. So although there is with the palliative care doctors. So we can say, well, all right, LVAD, we know that's why we're here talking about this case, because people can't agree. We also know that LVADs share properties across types, right? They're partially internal, they're partially external. They can be a substitute initially, but they kind of become a replacement. Now, when LVADs were first introduced, they were thought of as a bridge to cardiac transplant. But now the vast majority of LVADs, more than 80% of LVADs, are for this destination therapy. You just live with your LVAD. You carry those battery packs around. You won't get a heart transplant. You just live that way. So it has become, in a sense, a replacement for a malfunctioning heart. It's not a heart transplant. But then it's also only part of the heart. It's not the whole heart. So is it totally a replacement or not, right? You can see how it gets confusing. We've also touched on this, that LVADs reshape cardiac physiology. So the heart is not the same if you were to remove the LVAD as when you put it in. And then when we think about whether LVADs should be removed, it depends on a lot of things. Residual heart function. And this is interesting because if you think someone could still live for some time and is just going to be in horrible heart failure, their quality of life is going to go from quite good to quite poor very quickly. But if they're not also imminently dying, they could live with quite poor heart failure for days to weeks, maybe even months, probably not though. Most people on withdrawal of an LVAD die within an hour, but cardiologists sometimes have been surprised. This is all data from the paper I cited. Goals of LVAD, this is up to the patient and the team too. Is this a bridge to transplant or is this direct therapy, more than 80%? And then what does the patient think? One of the things they talk about in this paper is that an LVAD creates a liminal space where you are neither sick nor healthy. I mean, if you are an otherwise healthy individual with just a bad heart that doesn't pump well, now you have a machine that's pumping. You're skiing, you're doing all your usual activities, right? There's nothing keeping you back. You're a healthy person, except you're not, because you have a device that's a substitute, if not a replacement for your heart. So it's tricky. They call it this liminal space of not being totally sick or being totally healthy. And then they give us this way to sort of walk through it. And it's kind of as thoughtful as you can imagine, starting with, and this I think is probably the most important part, when we are called as ethics consultants here for question of removing LVAD, and we go back to say, what was that conversation when the LVAD was put in? We often find that even if the doctors feel that they've given all of the information, the patients weren't able to take it all in. And so it is now recommended, but not required, that even when you start talking with a patient about inserting an LVAD, that you bring palliative care in from that moment. And then you spin off all of the what ifs. And you even talk about the possibility of removing an LVAD down the line if we get to that point. So interdisciplinary, a lot of what ifs, bringing in the family. Again, this gentleman has far outlived the median survival with an LVAD. Probably no one expected him to live this long. Was that what if ever incorporated into those early LVAD conversations? An LVAD you put in when you're 68 or 70, you might think about it very differently when you're 80 or 85, right? They recommend that if conscientious objection is exercised, you should consider referral to another clinician. Cardiologists in the literature, when they feel that one of these devices is necessary, they get quite passionate about it. And some feel that it's even kind of hastening a kind of death wish if they don't put the device in. And so if you feel so strongly that your 50-year-old otherwise healthy guy is not making the right decision by refusing, then maybe you want to get a second opinion and encourage that. Assessing capacity. And this now is getting to this question of deactivation, weighing terminality. We might think very differently about removing if a patient has very complicated medical history and is even dying of an otherwise underlying disease versus a healthy patient. Thinking through options, and then incorporating palliative care. So if we return to our case then, and now I'm going to just kind of land the plane here and then open it up for discussion. What we actually know is that psychiatry followed this gentleman quite closely. They determined that he was severely depressed and lacked capacity. He continued to be actively suicidal in his first couple of weeks in the hospital. And psychiatry felt that if we could get him to an inpatient psychiatry ward, that he would benefit immensely from that therapy. However, psychiatry ward, especially here, cannot handle the LVAD, so that presents a barrier. He was given a one-to-one sitter, and he was given a really effective antidepressant therapy and actually made a good turnaround. Ethics called his longtime cardiologist, the cardiologist who initially placed the LVAD way back. And he said, you know, what I can tell you about this gentleman, amazing family, super supportive, but the littlest thing sends him reeling. He's easily overwhelmed by the smallest changes to his health, and it really drives his depression downward. And especially since his daughter died, he's just been kind of plummeting over the last year. Family, when we ask the family what they say he's definitely depressed, but not a single one of us agree with this decision. He has struggled with depression for many years, but this decision is not, he's not making this with a clear head. Don't go forward. And then we put him on antidepressants. I should say psychiatry treated him rather aggressively. And in 2 weeks, he was completely denied. He was in the hospital quite a while, so we had longer to follow him than what I'm giving you, but he completely denied suicidal ideation. He said he doesn't want to die. He does note he doesn't want to be a burden on his family, and he's worried about that. But he said, I promised my wife I would not do anything to hasten my death. I would not harm myself, and I'm going to stick to that promise. And so in the end, the LVAD was not removed. But this is where I'll stop, and I would love to hear your thoughts, reflections, and I think we'll be able to mic this, right? Or should
Yes.
we- Okay, we have a remainder. Great.
And just go back and.
Yeah, however you want to do it with the online.
And can I just encourage folks to talk close to the mic so that.
He thought, as a psychiatrist, he was depressed and suicidal. So if you're depressed and suicidal to go to autonomy, you don't have autonomy at that point because you can't, until you're better, if that's possible, think clearly enough to make that decision. And so my thought all along was, well, is he depressed? Did anyone ask him if he's depressed? Because he tried to commit suicide. He didn't ask us. He tried to commit suicide. He didn't say, Doc, did you do this? So starting with that, then what does it mean when somebody either tries to kill themselves in a psychiatrist's world or says to us, would you kill them? What does that mean? I'm not going to answer that question. But isn't there always that question of somebody who wants to kill themselves? What does that mean? And somebody who wants us to assist them or kill them, what does that mean?
Yeah, that's great. Do you want to reply? Yeah,
follow
please.
up.
Yeah, please.
I just want to follow up with what would it look like to want it removed and not be called without capacity? Like, is that even possible? Right? Because as soon as he says, I want the LVAD out, everybody's like, that's suicidal. You no longer have capacity. And so it's a circular reasoning, which makes it impossible to express what might it look like for a patient to be told, okay, we'll do that for you.
Very clear. Would it be different if you said, I don't want to do dialysis? And I've had it with dialysis. You'll die. I know I'll die. I just don't want to do that anymore. I would say the difference is, no, you shouldn't say you're suicidal. We get called on these cases, as you know. The question is, what's going on? Are you suicidal? Are you depressed? Do you understand? Why now? It is, I agree with you. Everybody says the patient is suicidal, who in their right mind would remove the drive line. And if you've ever lived with somebody who's had an LVAD, it is not normal life. Maybe you could ski. I've never known anyone to ski, but it is not normal life.
Yeah. Let's say that there's a scenario to answer your question, Martha. I'm 80 years old. They told me I probably had 4 years with this LVAD. I'm going on 8 years, 10 years, whatever. In the meantime, I've developed a host of medical problems. I've lost an adult child. Yeah, it gets me down. I don't want to hurt myself, but I'm not asking for death. I'm also not trying to cut my wires myself, right? This is a conversation with the cardiologist. Doc, could we think about maybe removing this LVAD at some point and just allowing me to go naturally? And we've had people who've approached it that way, and then you think, okay, this isn't sort of, an older gentleman alone in his rehab, sort of trying to monkey with the wires again and again and again. This is a sort of rational conversation in the setting of someone whose physical health is declining. You can imagine that the patient with metastatic cancer on top of the LVAD saying, they're telling me that I've gone through first line, I've gone through second line. What am I gonna do? Third line chemotherapy with an LVAD? Let me just focus on comfort and not drag this out with the LVAD. And so I can imagine a scenario like that. But anytime there's the attempt at self-harm prior to coming in, I think that's where our psychiatry colleagues, the bar goes up really high. Show me that he's not suicidal before we have this conversation.
Interesting, no knowledge.
Okay, so we have a question from one of the Zoom attendees. How might this case be viewed differently in a setting where medical aid in dying is legal in more frequent use?
Yeah, no, that's a great question. I mean, the sort of perennial issue with medical aid in dying is this question of whether patients are suicidal or not. But we know from US data, that at least in Oregon and Washington, the two states where it's been legal the longest, only about 3 or 4% of people who seek what we call physician-assisted suicide or death with dignity in those states actually are screened for depression. Which means that in the majority of cases of people seeking to die or to hasten death, there isn't the concomitant screening for depression, which raises all kinds of concerns. I know, for example, in Canada that medical assistance in dying, which is the term that they use in Canada, is typically lethal injection. I don't know if anyone here knows about LVAD removal as the precipitant of death. My sense is that because removing an LVAD, you're doing another surgery, right? If a patient with an LVAD wanted to hasten death, I would think, and qualified for medical assistance in dying in Canada, I would think that they would just go ahead and do a lethal injection rather than go through the sort of hassle and messiness of trying to explant a device that is now deeply embedded in the heart. But if others have experience with LVAD removal in Canada,
Not in Canada, but
sure.
they normally will just turn it.
They just normally will turn it off
Yeah.
without having to do any surgical intervention.
Yeah. And I think in Canada, they'd still do a lethal death. Yeah, it would be a lethal death.
Outside the US, lethal injection is really preferred because it works. And patients taking many grams of barbiturates doesn't always work. They end up seriously impaired in an intensive care unit, intubated, because they just can't take enough of the drug to die, but it harms them.
Yeah, no, that's right. That's right. So for the Zoom audience, the comment was that outside of the US, lethal injection is preferred. You're absolutely right. In Belgium, Netherlands, yeah, Luxembourg. Who else?
Well, a lot of different.
Okay, so if a patient meets the standard for decisional capacity, the Applebaum standard or whatever standard, but they express suicidal ideation, does that mean that they lack capacity?
Yeah, so this is where we would have psychiatry evaluate. So it's interesting. Our practice here at Columbia Presbyterian has been to, if a patient has an underlying psychiatric disorder, to bring psychiatry in formally for a capacity assessment. Everyone in this room knows that any clinician can do a capacity assessment. And so we don't need psychiatry, but when there's an underlying psychiatric disorder, we would. I think it depends. There's a way to express passive suicidal ideation, something to the effect of, can you believe the state of the world today? Maybe I should just, move to Canada or whatever, right? And that kind of thing is, people tend not to think the same as the act of cutting a driveline to a life-sustaining treatment. And so then where in that spectrum of kind of a very passive, almost flippant expression of despair all the way through to actively trying to end your life is what the clinician needs to figure out. And I think if there is concern that this sort of a passive expression of suicidal ideation could in fact be pointing toward an underlying wish for suicide or plan for suicide, then a clinician would get psychiatry involved. That would be my experience. Others have different experience. Yeah, that's our practice here.
Wanted to reflect on some things that you and I had talked about too, which is, to remind ourselves, as I think early on somebody with their question said that removing capacity or telling a patient they don't have capacity is a profound statement, right? We are all here hoping that we're believed when we say we want something or we don't want something. We use a capacity assessment to protect vulnerable people who are truly, we believe, need protection because they're not capable of making that decision. But this is it can be murky and it's so serious. So I think that, first of all, I just wanted to remind ourselves why that makes us so deeply uncomfortable. And then there's also something when physicians or we have to participate in the act, right? He could be on an inotrope, a pill, and stop taking it, right? We have we're less problematic. It's less problematic than when we're asked to actively participate in what's going on. And yet it is also a power that we have when we're asked to participate because we get to say yes or no. Like we will do this for you, particularly in AICDs, right? We will do this for you or we won't, and you can't do it on your own. So you're depending on us to believe you or give you the power that you're asking us for. So I'm just sort of highlighting some of the things that we talked about this case that are particular, that bring things up for us as in ethics.
And that's great. I mean, we always question patients' capacity when they disagree with the doctor's statements, right? That's when capacity comes into question. I do think there's a particular sensitivity around questions of suicidality, but even still, as the question from the Zoom room attests, it gets really messy when you're talking about jurisdictions where it is legal to hasten death, where it is legal to end life for interminable suffering, which, you know, in Canada now, since 2021, it has been legal to undergo MAID for interminable suffering, regardless of having a terminal diagnosis, that the suffering alone can be a reason to end life. And so, you know, he could have said, I'm suffering greatly. And he may have qualified in a different jurisdiction, but at least our hospital has been very careful around questions of suicide.
Quinlan's parents, that the extraordinary need was based on they felt she was suffering on the bench.
Right. Yeah, for the Zoom, Quinlan's parents, the extraordinary means was that they felt she was suffering on the ventilator. Yeah, exactly right. Yeah. Please.
I thought it's interesting how a big part of this discussion rests on those ethical frameworks that you mentioned, essentially what modality removal of an LVAD would fall under, and whether that is removal of life support or one of those other ethical modalities. And so I was curious in terms of looking at it from like a legal standpoint, in the coming years, do you imagine that there will be a legal precedence or some sort of official designation of LVAD as one of those modalities? What does that process look like? Does it involve patient cases that are sent to courts and then essentially precedent based on that?
Yeah, I mean, I think generally most people feel that this falls under the rubric of life-sustaining treatment, even though it's complicated, right? Is it external, internal? Well, you know, is it regulative? Is it constitutive? That is all of a framing I sort of gave to you to help give some structure to the conversation. But at the end of the day, what they give us is that you kind of have to do your due diligence, make sure the patient fully understands. And even if this is a young, healthy patient who is asking for removal, and you think it's completely wrong, if you've done your due diligence and the patient has capacity, they legally can because of the Quinlan and Cruzan cases. It falls under that sort of life-sustaining treatment. Now, what hasn't been tested in courts, and what I can't imagine ever will be, but to answer your question and push it, is what if we're talking about removing a heart that has been transplanted? And is that a life-sustaining technology, or do we? What if it is a completely fabricated heart, and we know we've optimized our technology such that we can use a pig heart? Now, nothing about this isn't a human organ, and there's no shortage. And we're putting these in everybody because we've got so many coming out of the pigs, like there's no supply problem. So we start thinking about organ transplantation differently. And now a patient says, you know what, I have had so many problems. This is an artificial technology anyway. I want my heart cut out. Would we do that? That I think is something that would go through the courts. I think that takes it up several notches.
It will.
You think it will go through the courts? Yeah,
The chimeric organs now, I
yeah.
know that there are that many built, but if they do become widely available, it's not even a human heart. And I don't want to grow a kidney
Yeah.
or a liver. I don't want to live this way.
So the comment in the room is that with chimeric organs, not so many yet, but will go that way. Once there's no supply problem and it's not considered, it's considered an artificial technology, why wouldn't you just remove it? Right? Yeah, that's true. Oh, wait, sorry, microphone's coming.
Hi, thank you. So I'm the director of the Psychiatry Consult Service. So I just want to make the comment that even patients who have psychiatric illnesses, including psychotic illnesses, including depression, we sometimes say, yes, the patient has capacity, and it's not a blanket thing that will say, oh, the patient is psychiatrically ill and therefore lacks capacity. I also just want to comment on this last point that there is a kind of a slippery slope that's entering here. You could have patients saying, well, take out this aortic valve that you implanted. Once you start going in that direction.
Yeah, no, I think part of the reason I had it in my mind about cutting out the LVAD, that you're totally right about just turning it off, is because Barbara and I have been talking in preparation about another case of a young man with a fatal arrhythmia who had an ICD placed and did not like the way it looked. And it embarrassed him when he was having sex. And so he wanted it cut out, which is why cutting things out was in my mind. But you're completely right. I want to just underscore one thing you said, which is the slippery slope question. How much are we going to take out? But also the autonomy question. Just because the patient is psychotic doesn't mean they lose autonomy. And we, on some issues, it depends, right? So autonomy, we're always talking about capacity relevant to a specific question. And then the question of autonomy versus capacity is relevant to that specific question. So I say to the med students sometimes, like, a patient might not have capacity to consent for open heart surgery, but knows that he doesn't want a hamburger, right? And you're not going to force feed him a hamburger if he's refusing that. And so it all depends, and it is a spectrum, and that's why we have to be very careful when we're talking about taking away autonomy or even curbing autonomy that is very focused and is absolutely critical, and that we do that with the utmost caution. And especially if it's a death wish, that's where I think we should always go more slowly. So in the case of the young man who wanted the ICD out, they deliberated with him and family for 8 months before they finally took it out. And they acknowledged it was a kind of paternalism. They took it out. He had a cardiac arrest, completely destroyed his heart, and then had to have a heart transplant. This is written up in the A-job. Dr. Rothschild kindly should do yeah, so, yeah, online, another online question. Oh, and in the room.
Thank you. Did this patient have any interaction with the chaplain? And if not, how do you think a chaplain might be helpful in a case like this?
So I off the top of my head, don't recall. In my notes, I didn't have reference to chaplain, so I apologize for that. It all depends. As we know, some patients and families warm right up to chaplains. Some don't. Some want their own priest or cleric or religious leader in the room. Others don't want anything to do with anybody who's even remotely spiritual. So I think it all depends, but I love our chaplains here. I think they do an amazing job. And in many occasions, I can't speak to this patient in particular, chaplains can be the bridge to building solidarity with patients that the clinicians might not quite get there. And I think our chaplains here are extraordinarily empathetic and do a great job of building rapport with patients. So certainly it can be very helpful. I know we're at time. There's one more question in the room. What do you guys think?
We'll take the last question.
Last question, then.
I was curious about kind of the interface of the medical aid in dying, and we're talking about potential future of, someone wanting a heart X plan. In that case, if you're going to remove someone's heart, which will cause them to die, I hope this doesn't sound like cavalier, but kind of what is the point of doing a whole surgery to remove someone's heart if
you can just inject them with
Yeah.
potassium chloride or something else that takes care of it, right, like that. Yeah, and I think it depends on if you're living in a jurisdiction where it is legal. So this is why I think, back to the earlier question, this would have to absolutely be tested in the courts. I know nobody who's cutting, well, I mean, some places where medical aid in dying is legal, they are considering, rather than having the patient die through lethal injection, have them die by organ removal, because then that organ is still quite, is optimized for reimplantation. So I don't think that's legal anywhere.
I think also it's important to think that autonomy it's not endless what you can request, right? I mean, I agree with you. You can think of it as far as what you want your endpoint to be, and shouldn't we just be then dealing with the endpoint that the patient wants? Because there are limits to what you can request as a patient and what physicians are obligated to provide to you. So I think that's also part of that conversation.
Yeah, and many institutions have policies on non-beneficial treatment too. So I could imagine an explanted organ falling under something like that, which just isn't beneficial. But all of that, I think is to be determined. On that very happy note, thank you for your attention.